Welcome back to Luna Unscripted, everyone, where we talk about real life, real career paths, clinical insights, and just share the nitty-gritty details of life as a PT. I'm Katie Wiley, one of your hosts.
And I'm Joe Valdez.
And I'm Marcia Arenas.
All right. Well, welcome back, everyone. How's everybody's week been?
Mine's been pretty good. We were just talking about, end of school stuff. I don't have kids in grade school yet, but I have a preschooler. And so just a lot of activities and random spirit days like pajama day and like water day. And, they're inviting all the parents down for stuff. So it's been a little bit busy, but it's starting to slow down a bit.
Yes, welcome to that world. Yeah, they cram everything into the last couple of weeks of school. So we've had field day and literacy night and magnet celebrations, all that happened to be in the middle of the day, or you have to send them extra clothes. So that's been fun. But yesterday, speaking of daycare, my son's daycare had the 100th day of school celebration. And the moms were texting before, like, oh my gosh, I don't have anything for them to wear. And I was like, listen, when daycare is year round, there's not really 100th day of school situation happening.
Right.
So I'm not worried about this one.
I'm surprised you guys just had your 100th day of school. They do it like from our school year, like collectively. So ours was like a little while ago, but no, I know they really just, I don't know. It makes it festive, right? That they have all these activities towards the end of the year. But just the logistics of it, and you're like, all right, I have to remember you need to wear this today, and you have to have a disposable lunch bag because you're going on this trip, and like it's just chaos. But the kids love it, so at least that's fun. But the parents not so much. But we're
And the
almost
amount of money that like the end of the year requires with teacher appreciation and end of year stuff and all the end of year parties and things like that. It's like Christmas again.
Exactly.
Yeah. All right. Well, on a positive note, today is a very exciting day because we're talking about my favorite body part to treat, which is the shoulder. The shoulder, I have just had a strong fondness for it throughout my whole clinical career. And yeah, so we're just going to get into all the details about the shoulder today, things we love about it, or maybe you guys don't love it. I'm not sure. We'll get your insight too. Fun diagnosis, maybe least favorite diagnosis, things we use for treatment, and yeah, just all things shoulder. So, do you guys share my fondness for treating shoulder patients?
I do enjoy it. I mean, I've had a lot of experience with one of my clinics and doing shoulder stuff. And I think we had a referring physician who sent a lot of like post-op shoulder patients. So I do enjoy it. Probably not as much as you, Katie, but it is a fun body part to treat.
I will share Joe's sentiment. Not as excited about the shoulder as you are. I don't know if that many people like you're probably top 5% of all PTs in the love with the shoulder. I prefer it to any part of the spine. And basically below the shoulder, I pretend doesn't exist. I'm like, oh, you need a hand therapist. Um, so yes, definitely like the shoulder, but my favorite body parts are definitely lower body.
Okay, got it. Yeah. I don't know what it is about the shoulder. I feel like so in my orthopedic classes, like going through school, that was one of the first things we learned. And it was one of the first body parts that like really clicked for me. Like I just, the complexity of it and all the muscle groups. So I think it kind of started there. I had some really good instructors with the shoulder back in school. And yeah, I just feel like it's nice in that it's not a weight bearing joint. So sometimes it's hard for people to like calm down the weight bearing joint areas, right? Because you're constantly on your feet and moving around. Whereas with the shoulder, with like some adaptations, I mean, there's just so much to love. So yeah, I love the complex anatomy. I love being able to educate patients. I feel like they don't understand that the shoulder blade and like the thoracic spine are really part of that like treatment and that complex. So I like the education component of it too. Yeah, I just love me a scapula, right? Like just being able to
I
work
do
on
love
the
a scapula.
mechanics of it and improve upon that and like calm things down there, I feel like is very rewarding. So yeah, that's where my love of shoulder comes in. But let's get into, so even, you like the shoulder some, what are your favorite things to treat shoulder wise? I'll let you guys go first.
In terms of like diagnoses, is that what you're
Yeah,
getting
let's
at?
go diagnoses.
Yeah, so I think rotator cuff anything. So post-op rotator cuff, I like how very structured that is. First 6 weeks, passive motion, calming symptoms down, kind of going through more aggressive movement phases, light strengthening, and then getting all the way up to the return to sport if they're up at that level. So I really like how it's very like cut and dry in terms of like you start here, we're gonna get to here, and the progression's like it's a lot. So rotator cuff's great, but also the people that don't have surgery that just kind of deal with random like rotator cuff issues, like the subacromial, what they call like pain syndrome, and helping them kind of modify their activities and improve movement mechanics. So I love treating anything rotator cuff related.
I would say that's probably my second. My first one is just like dyskinesia in general. Um, so working specifically on, or like if they're doing overhead motion and they get like stuck at like 160 or something like that, and then like how you get them to 180. That was actually me in PT school. Um, I was like doing something shoulder and I lifted my arms up to basically here. And Shirley Sarman, who's I think she's like 100 something at this point, but she's like the godmother of some of the movement system stuff. And so she was actually in our lab that day. And she came over and looked at me with this like face and was like, then like moved my shoulder blades and did a couple other things. And then my arms went all the way up. And so it was kind of like an aha moment about the
Like it's
shoulder.
like
Um,
magic, right? It's so amazing
yeah,
how much
yeah.
difference that can make. Oh, yeah.
Yeah, so I love dyskinesia and teaching people about the scapula. I was much more like gung ho and into it younger in my career, and then as I've seen, some patients don't pay as much attention or don't really try or don't carry things over, it gets a little like disheartening. But dyskinesia and then rotator cuff stuff after that. I actually have a partially torn rotator cuff, so I can definitely demonstrate to patients the difference in motion side to side, which I think is helpful. I do not like anything related to really frozen shoulder, that whole kind of set of diagnoses. And I don't really love slap type tear stuff either. I think because I'm not as good as at testing it. We can get into all the special tests later, but I had like this whole like movement dance thing I did to try and remember all of them in PT school.
Yeah, I think we're on the
Yeah,
same
I see
page
that.
with like least favorite diagnosis. Yeah, I'm on the frozen shoulder is probably not my favorite of them. Though, I mean, depending what part in this, phase of things you're getting them, it can, turn around quickly, but for the most part, it's a real slow process. And yeah, labral probably not my favorite, but yeah, frozen shoulder more difficult, obviously. But yeah, I'm with you guys. I like the rotator cuff injuries, like the partial kind of tears where you don't have to have surgery. I really love that. And like the impingement syndrome. And again, like you're saying, where people get stuck in their range of motion too. I feel like there's so much you can teach them and like a big difference you can make in that. So I really, yeah, I enjoy those diagnoses. Post-op shoulders, I do like. Obviously, they're real painful in those early phases of things. It depends on your patient, but some of them are just in an extreme amount of pain. So, I mean, it's a good one in that you see a lot of progress with it, but just the delicacy early on, and you always feel bad when people are like, "This is for your own good, I promise," and we're not hurting anything. Just getting it going is not always the most fun early on. And as they're getting back to things, it is rewarding, and you see a lot of change.
Yeah,
Um,
except for maybe the reverse total shoulders.
right.
The reverse total shoulders are like the one surgery I'm like, if I have to deal with that, I just know it's going to be a struggle. And I feel bad for the patient, because their shoulder is coming in completely shot by the time they get that. But yeah, all the other ones are pretty good to work with, I think.
I feel like the reverse total shoulder as a concept, like, it's just amazing to me. Like, who thought of that, right? Like, let's just go ahead and like reverse the whole mechanics of it and get this other muscle to take over. I find that area like that's just an awesome just concept. But no, I'm with you. That can be difficult. And obviously they don't have the mobility afterward. But just a cool idea. Who thought of that? What are the most interesting ways that people have hurt their shoulders for you? Any like funny stories or situations of how people have hurt themselves? Um, For me, somebody like rolling over in bed, like dislocated, we had that before. That's one that stuck out. I think I had a bull rider one time, like, rodeo kind of person. I'm sure you guys get that
Cool.
in Texas too, right? Some of those more rodeo related injuries and such.
Look at her like thoughts of Texas, Joe. She just thinks
I know. I
everyone's
know
wearing
nothing of
cowboy hats
Texas.
and
I've
belts.
like flown through Texas,
That's
but I'm like,
that
you
is a
guys
very
gotta have
niche
rodeo down there.
that is a very niche population here, but I have had people that have worked on ranches and maybe had to like lift a hay bale up and like they like injured their shoulder on the upward movement, or maybe just you know moving stuff all day, or maybe did have to like reel in an animal of some sort. But those aren't as common as people think when you're outside of Texas.
Like, isn't that
I've
everybody in
also never
Texas
seen
with
that.
their boots and their cowboy hat?
Yeah. Yeah, I've never seen anyone that works on a ranch or in a rodeo.
Really? Okay,
So
surprises me.
true, but I will say that goes into like my whole when I moved to Texas, I'd unseen people said Dallas was more cowboyish and Houston was much more metropolitan. So by this conversation, same thing. Joe's in Dallas and I'm in Houston. Interesting. Um, I have also had the people that roll over in bed. And it's mostly for me, it's not even the shoulder, like the way they injured it. It's the things that they say like hurts. So like they have pain, but doing like something like that is like that's what hurts. I'm like, why are you doing that? Or
That would be the reaching into
like
your back seat to get something for the kids or hand them something, or they drop their toy. That's what that move is right there.
that
I
is
know
true.
that.
That is true. My heavy water bottle, I pass to my son sometimes and he'll hold it to me funny. And I'm like, my shoulder hurts when you do that. These are
Mhm.
usually, no offense, Joe, men. And so I know that they're not doing that. So I'm just like, why are you doing that? Or again, I find this again, sorry, Joe, to be more man related. And my husband does this specifically, but I've had two shoulder patients that do this. They have shoulder pain and they just like keep moving. They're like, I don't know when I do this. And I'm like, stop moving. Like, why you're just irritating it.
I did have a guy, he was a man, who would he would jerk his shoulder, he would lift his arm up to like 90 degrees like this, his shoulder, and then just like jerk it back really quick into like external rotation. And he wasn't like a pitcher or anything. He was just like, yeah, when I do this motion, it like hurts really bad. I'm like, well, you never need to do that for anything. So why are you doing
That is
that?
not a
It's just kind of
functional
interesting how
motion
people
for
will
you
find
to do.
ways. Exactly.
Yeah. No, for sure. Or the comment, I feel like they're like, well, it feels great. And then they like poke real hard, like right in the bicipital groove there. And they're like, but that really hurts. I'm like, I mean, maybe don't do that. Like, I don't think that's really going to come into play in your life too much. So just like keep your finger out of there. You're like poking a bruise, poking right over that area. So yeah, I frequently will, let's just hold off on that because you're just making it more angry when you do that. Um, well, I, as a clinician, use posture a lot. Obviously, I'm sure you guys too, to work on shoulder pain, right? Because, as we know, when they're real slouchy and rounded, we have less room, more of that impingement type of symptoms coming through. So, posture is a huge part of what I work on with patients. Do you guys have go-to posture things or tools that you work on with patients to help cue them and remind them about those elements?
I mean, I just try the tried and true like scapular type retraction movements, the chin tucks and kind of have my little progression of how I do that. But at the end of the day, I feel like what I tell people is not being in one position for an extended amount of time is more important than just focusing on like having the perfect posture all day. But I agree. I think posture is a great baseline for establishing, good shoulder movement. Because if you have bad posture, you're ultimately going to have bad shoulder movement.
Agreed.
Yeah, I tell patients, I think it started when I did PD, but it extends to now adults too. I tell patients that, um, well, I'll talk about when you're like this, it's tight here, the back muscles stretch out. So when we talk about improving like some scapular, a little retraction and posture, I tell them there's no way you're going to stay like that. Like your body is trained to come forward. Those muscles are weak. So like what started with school age kids and now I do it with adults at work. I'm like, every time you're bored at work or you happen to look at the clock, reset your posture, squeeze your shoulder blades, set your chin back a little bit. your body's going to eventually go back to the posture that you were in, and that's totally fine. But the more your brain can start signaling those muscles to start working, the more subconscious, unconscious it becomes, the stronger those muscles are. Um, so with the kids, who knows what happens with that? I do that also for core stuff, but the whole like, hey, you're bored in class, ha ha ha. See, I relate to you. Uh, Look at the clock, fix yourself, and then go back. I do feel like though, since everything has become computer, like even at school, Katie, I don't know about yours, my kids use iPads at school, that everything is just so rounded now that it's
For
even hard to get them
sure.
out of any type of posture like that.
Yeah, yeah, same. Yeah, my kids are definitely already, they're kindergarten, second grade, and they're already using computers and tablets. So yeah, everything does bring you forward for sure. I use the reminder system too. I know you were mentioning that as well. So I usually, so like if it's somebody who's like working, on a computer, I'm like, all right, set a timer every like 30 minutes or every hour, whatever it is. I mean, that's just good to get up and stand anyway, but just as like a postural cue. Or if it's somebody not as tech savvy, like putting a sticky note like around, so every time their eye like drifts up to that, then they kind of like,
Oh,
okay, I should sit up a little bit straighter. So I use those too.
I like
Um,
that sticky note. That's a good one.
yeah, it just keeps it in mind. So I also, do like Joe, do like the scap squeeze, I think most of us do. I know I mentioned kinesio tape on our first episode as one of the things I'll use. I use that for like the postural cueing, so like rhomboids, lower trap kind of activation taping that I find is helpful. And people are like, oh yeah, it really does kind of just like give that like light cue to like pull back more. I like a half.
Yes.
Oh yeah, yeah. I use a half foam roll behind the back too. Have you guys ever tried that? Like kind of vertically? Um, so sorry, my cat nudged her way in here. So if you hear meowing in the background, that's Luna actually.
Perfect. Luna's making a little guest cameo.
Making her debut. She gets real interested in what I'm doing in here when the door is closed. So if you see her, no.
Oh,
Um, I use like mirrors too, or like tactile kind of when patients, help themselves pull back into that retraction. Yeah, those are my big posture things. But I do like a half foam roll. If you haven't tried that, the vertical half foam roll behind the back as they're kind of working on that, I feel like they can like feel the squeeze back better. Nice.
I like that idea. I also use the kinesio tape because I found, and it's not the general like population's fault necessarily. All these things are being thrown at them, but a lot of people will ask me about like if it's a female, they'll ask me about the bra, or they'll ask me about those kind of like shoulder things that basically force them back in a posture. And so you have to do a lot of education on how like it's holding you in that position. It's not teaching you to use your muscles. And so I think kinesio tape's like a nice bridge because it does do a little bit of that with more so like feedback. So I'll start with that specifically so they can feel what it feels like without being something like getting like a harness or something that they saw.
Yeah, I've had a lot of people ask about those, like the passive ones. Although I think there was one patient I had who got it was like a buzzer. So like it was like this little device they put on their like thoracic spine, like upper back. And anytime they rounded and the angle reached a certain area, it would like vibrate to remind them. Great in theory. However, with this specific individual, they were already fairly kyphotic. So it just thought they were slouching all of the time, which I mean, theoretically they were. So it didn't really work out in that situation. But for like somebody at home, I could see that. Like if you're in front of the computer, right, and then you start to round a little bit, it'll like kind of vibrate and remind you to like come back up. That I thought was a good idea. I hadn't seen that.
It's almost like a dog shock collar, just kind of
I was gonna
training.
Kind
say
of,
I would
yeah.
like the shot collar. Yeah.
I don't think it was like an intense one, but yeah, I mean, kind of. Yeah, really. No slouching for you. Not allowed. Yeah.
Yeah, you mentioned the like kyphosis in the thoracic spine, and I feel like on the manual side of things, I really love working on mobility of the thoracic spine.
Same.
Either through mobilizations or manipulations, or even like driving the muscles around the thoracic spine in between the shoulder blades, because that, as we all know, that greatly affects like the positioning of the scapula. So, trying to provide them with tools as well to improve their scapular mobility with some exercises, or not scapular, but thoracic mobility with some exercises, I think will naturally improve their posture as well.
I
I
had to learn
agree.
that over time. I wasn't very good with the thoracic spine, especially initially on, but then as I kind of saw how they went hand in hand, it was I kind of opened my eyes up to seeing the thoracic spine. Y'all remember in PT school when like you were learning about the scapula and the 8,000 things it does and how you'd have to like hold your hands up and be like tilting and rotation and all that kind of stuff. And even now, like it's funny if you see newer grads or even like on some patients, I have to be like, okay, like where is it sitting? Like all of that kind of stuff. Just always brings me back to school learning that.
Mhm.
Yeah, I think we had some sort of like dance or some like choreography to like how it moves in different ways, but I don't remember at all what that is.
Oh, I want to see you dance.
Oh no. No, this isn't TikTok. This is a Spotify and YouTube. So.
Random but related to thoracic mobility. I have one of these at home. I've never used it with a patient, but I like it myself to like keep myself in check. Have you used a chirp wheel before? Do you know what those are? It's kind of
I've
like
seen a lot of advertisements for them.
they're good. Yeah. So I have one at home. And basically I just use it in my thoracic spine. But it's like the idea of like a foam roller, but more like then you don't have the foam roller going over your scapula, it stays like just along the thoracic spine. And you can kind of mobilize yourself. And I usually get a good crack there, especially at the end of the day. And it's a good one for me. I like it. Get my extension
Oh,
better.
that's a
Yeah.
good one to recommend to patients specifically who have like desk related type jobs.
Right. And if they're, because it takes a little like maneuvering, right? So if they're coordinated enough for that. But yeah, it's good. I like it. It's really neat. Have you guys
How do you
taken any?
guys
Oh, go ahead.
How do you guys, what's a good way? I think this might be something that like I still have difficulty with. I'm sure a lot of clinicians do. We explained the 2-to-1 motion of the glenohumeral joint, the upward rotation you want when the arm goes up, but I always like, I learned the like there's a string between your elbow and the bottom of your shoulder blade, and as your arm goes up, you want it blah blah blah. Do you guys have good ways of kind of cueing that so people can understand or try to pull their shoulder blade around? I haven't found a great like cueing or imagery or something like that.
I think like
Oh, wait, you got one,
tactile,
Katie?
right? Like so say somebody's doing like a wall wash or anything, just like being back there and like manually kind of facilitating some of that, I feel like is nice, right? So they're not like getting into those shrug mechanics with elevation. I often like them like on a wall and or with like a foam roll so they can feel it a little bit more, like again, vertically behind their back. So I feel like it just like you can tactily feel that movement better and you can kind of talk through it. So if you have them work on like flexion or scaption at the wall and just being able to, I don't know, that anything where they can like feel what's going on and you can kind of talk through it while they're doing it. Side note, just a really great perk of being able to work one-on-one with patients too, because if you're in like a crazy clinic, that type of queuing doesn't really happen, or it's less prevalent, but just having some one-on-one time with patients really makes a difference. So you can lean into the like quality mechanics and make sure that they're actually doing those things properly. But yeah, that's kind of my go-to with it, just so like you can kind of like talk them through what should be happening and again, avoiding the shrug kind of mechanism. Yeah, that's what I do.
Yeah, and I kind of agree with Katie in terms of like explaining is one thing, but when you explain it, they're not really going to understand what's going on. So getting your hands on the shoulder blade and doing like mobilization with movement while they're doing things is a better feedback for them than verbally explaining to them. And we talked about kinesio taping. I have done some of that with also Leuko tape. I don't know if y'all have used Leuko
Mhm.
tape before. So it's that rigid tape that
Yeah.
you can physically, you know, move or like hold the shoulder blade or whatever joint you're working with in a certain position to kind of help cue them for what it needs to be doing. So I have
Yeah.
used that as well for some proprioceptive feedback for different
Just like a
things.
lower trap taping, like the diagonal kind of from the top of the scapula down.
Yeah, so that's one
Yeah.
of them that I've used
Yeah.
for
That's
that.
the
And
one
then
I've
also
seen
just like
before.
regular scalp retraction as well. Yeah.
Thanks. Yeah. That one's a little more like there's less give to it, right? Like it's a little more like you're gonna stay back there, right?
Yeah, very rigid for sure.
Yeah. Yeah, that's what I thought. Yeah. Nice. Good cueing for
That's when
that.
you have to, when you're cueing the shoulder blade, that's when you're like, all right, now I'm going to get up real close and personal to you. And you like have them move their arm up and you go like this. I do find that patients like when you're doing it and they're like, I can only get here. And then you're like, hey, do it again. And I'm going to help you with your shoulder blade this time. I'm going to act like your muscles. And then they can get up. It's really an aha moment. It's just trying to like recapture that with things that they're doing outside of being with me. But yes, the one-on-one Washi was was very regimented in the training hands-on all of the time, queuing. And so going into a clinic where I was seeing more than one patient at a time was really like, what do I do? I can't focus on the things. So coming back to a more one-on-one experience with Luna has been very helpful with that part of it. I feel like I'm able to contribute more to a patient because I can actually do some tactile biofeedback stuff.
Exactly. I mean, that just goes for all body parts, but especially with like scapular related stuff, I feel like it makes such a difference. I've taken some good continuing education courses. I did one early on in my career, a Kevin Wilkes class. It was knee and shoulder. Are you familiar with him? He's like one of those sports rehab gurus who's treated a lot of athletes and things like that. But yeah, this was a really good class. I liked his, and I was looking because this was like years ago when I first started. It was a course down in Atlanta, actually. It was a fun adventure of getting down there and battling Atlanta traffic, and so it was just me going, but it was fun. And then I did one locally here that, shoulder, but other related. It was all about upper extremity neuropathies. Because as we know,
Ooh.
sometimes that comes into play when we're treating the shoulder. And that kind of leads me to like, do you guys ever notice? I know this is common for me, like the neck versus shoulder conundrum, like which is causing your pain? Like, I feel like that's such a common thing I hear from patients, and they've been to our spine doctor and our shoulder doctor and back and forth and had MRIs of both. And what is truly causing it? You guys see that too?
Yep. And it can be tough sometimes to differentiate
Yeah.
between neck and shoulder. And early on, especially when they're so irritated and inflamed, I just kind of go with both, right? And then I think down the line you kind of weed out, oh, this is definitely more shoulder versus neck. But they're so closely related that I feel like treating both isn't a bad thing, right? To just kind
I
of
totally
simultaneously
agree. Yeah,
take care of
for
it.
sure. Yeah. What
I
about you,
need
Marcy?
one of you two to be close to Houston, closer than Dallas, because that's like me right now. For the last like 3 weeks, I've had like uh nerve pain in my bicep, tricep, and then to my forearm. Comes and goes. I've been trying to figure out whether it's neck or shoulder related. I have a bunch of knots, but I don't know. So treating both as best as I can. But yeah, I mean, every person could benefit from, I feel like I call them the neck abs,
I
the
think that's what
intrinsic
I
deep neck
call it
flexors.
too. That's funny. I always tell patients it's the abs of the neck. Yep.
Yeah, I'm like, you want to strengthen the six pack of your neck. No one cares about your chin type of thing. But so I work on both of those. But yeah, it's hard to weed out, especially kind of like in this range here, which is evident by the fact that I'm a PT and having a hard time figuring out my own issue right now.
Right? Yeah. And I'm in the same wheelhouse as Joe. I always am like, you know what? It's probably a little bit of both. And we're just gonna address both things, like it's hard to decipher, and most people have multiple things going on. And I'm like, that's okay, because we're just gonna treat them both, and we're gonna address the symptoms. And then, like you were saying, if one tends to be kind of we're like, oh yeah, I'm pretty sure it's for sure that, then we can kind of go that route more. But yeah, a little bit of both doesn't hurt. But yeah, I remember not getting a lot of necessarily training or education on that early on, but as you see more patients, you're like, this comes up all of the time. Is it the shoulder? Is it the neck? Is it the shoulder? Yeah, yeah, when patients are concerned about it. But you treat it both and you get the great effects, and you're able to work on that nerve mobility and your rotator cuff strength, stability. Good
Have
things.
you seen any patients with TOS? I feel like TOS oftentimes gets lumped in with shoulder, with all that kind of stuff as well. Um, Joe looks like he's primed to
I
say something.
mean, I think we've had people with that diagnosis come in and we're like, it might be, but that is such a the more I've studied, the more I find out how complex TOS is. So it's hard to say if those handful of patients truly had TOS. I think of those maybe like 4 or 5 that I have gotten those diagnoses. Most like 4 of them or 90% of them have gotten better, whereas one we're like, we're just not seeing much here. You should probably go back to your neurologist and get reassessed. So it's hard to say, if I've truly had it or not, but it's tough. How
For
about you,
sure.
Katie?
Yeah, no, agreed. I feel like I haven't seen a lot of like the vascular component with it. You know how like, the traditional TOS are typically that vascular. I haven't seen a lot of that, but more of again that neural involvement, that pinching and that symptom reproduction, but not a lot of the vascular.
Yeah, I feel like a lot of it is could be more impingement related than true TOS, but I would have seen more neural stuff. I have seen one patient, actually, she was a PT, who had I mean, you would see it in her hand, the vascular changes and like start
I
to go
always
all the way
remember
up.
the
Yeah, it was
test,
pretty
right?
crazy. The East test, yeah,
Yeah, I
or
always remember.
Root, they call it both things.
So do you guys have go-to exercises that will maybe talk through exercises, manual treatments that you use, and modalities that you use generally for shoulders? I know exercise wise for me, I know we were talking posture, the scap squeeze, and like the tools I use. I always make sure people breathe with that. I know I told you I'm into breathing, but people hold their breath all the time with that, and that they dissociate, they don't get like the huge lumbar movement with that too. Um, Early on, I like a supine or like hook lying band, like horizontal abduction. I feel like it's like an easy way for them to get the feel for that and like feel like they're doing something because it's like against a resistance. I feel like that's a nice way to like train success early. Um, Rotator cuff wise for me, I'll do I like a sideline external rotation. I feel like of the external rotation to start with, that one has less of the compensatory strategies versus like throwing a band at them straight away, right? Like I just want to keep the upper trap out of it, like, right? Just like keep everything calm there. It's always hard to figure out what works for people. Um, those are my go-to early on ones. For like higher level, I like the ball on the wall or like wall kind of taps like through an arc too with a ball. Um, Rhythmic like stabilization where you're like manually working on those things too, especially, throwers or things where they might have some various contact. And I like a body blade. Have you guys used those? Where they have to like,
I have, yeah, those are kind
yeah,
of
yeah.
fun.
They have
I
mini
think
body
they're
blades
great.
too. Have you used the
Oh
mini
yeah,
ones?
I have one. I have a
Yeah.
mini one.
Yep, I love those. I remember because the big body blade, you'd be like, oh, I can only use that with like my like athletes, those super strong ones. And then we found the mini one. I was like, yes, everybody gets a body blade. I love it. Um, yeah, I feel like those are my go-tos. Which ones do you guys use a lot?
so I mean, kind of along with you, Katie, very similar with those strategies, but I really love using like looped bands for engaging the
Okay.
rotator cuff in like upward motion. So I like have that robot exercise, where you got good posture,
Yeah.
90-90 here, trying to get up here, but then you have that band around their wrists where you're like isometrically holding that external rotation. I love that because I feel like it engages a lot of different things. And no
Mhm.
matter how strong the patient is, if they're like a bodybuilder, power lifter, high level athlete, it always humbles them and they always need work on that particular motion. And then if
Sure.
I want to maybe engage like the serratus as well, I'll put them up against like the wall and have them like do that while pushing into like a foam roller going up. And once again, humbles everyone that works on it. So I love using that one. And then
Isn't
also
it
like when we get,
funny? Like anything external rotation related, like is so there are some who are so resistant to the small weight that you give them, and then they fatigue out so quickly with it. It's a common theme, I think, with treating the shoulder and people who are like, I lift, whatever, hundreds of pounds, at the gym. And I'm like, well, we're gonna start with a smaller weight for this because you need work on that. You do the manual muscle testing and they can barely hold anything. You're like, we're gonna we're gonna need to start small.
yeah, they almost get offended when I grab the yellow band, which is the lightest resistance. They're like, come on,
Uh,
Joe. I'm like, all right, let's just try it out and see. And they're like, okay, like this is tough. And they might not even progress much past that. But I love those ones. And then for the higher level people, you mentioned like the ball on the wall. So any sort of like weight bearing through the shoulder, there's like studies that say that the engagement of the rotator cuff when you weight bear is just a lot higher
Sure.
And so like I'll even get people like weight bearing through a table or like even like in a high plank and then doing different motions there, like with bands or like pulling stuff through like kettlebells or something like that. So I love doing that when we get to the higher level athlete. It's like getting some weight bearing through their shoulder.
Yep, same Joe, same. I am a wall girly. I love the wall. So as soon as I can get them on a wall, usually first session, we're on a wall. We're doing basic wall slides, working on the scapular mobility. Um, we're doing hands on the wall with the circular rep band, like stars, then little like push up plank type things, turning around and doing, they call it reverse T in MS Island, but it's like doing arms overhead, trying to get the lats down. I feel like the lats get involved or overly tight a lot, which can affect the breathing also. So we work on trying to keep the core and the lats down. I do all kinds of stuff with that circular rep band in different like ways above and below. Um, I have recently got into, yes, weight bearing. So I won't go over that again, but kettlebell stuff where you're holding a kettlebell with the bell part up and you're just doing very basic motions or even holding it still and turning your body. Um, so recently more into kettlebell type stuff. And then also into, I got like a body blade, but it's more so, for hand therapy, it's like uh, a flex
Oh,
bar
so
that you can.
those tubes that twist,
Hair
right?
Yeah.
bar,
So
right?
instead they do very, yeah, small movements
Yeah.
like that or like rotation behind your back and stuff like that. Um, I love being on TikTok or Instagram and just scrolling through different PT videos of different weird shoulder exercises to do. My patients are always like, "What torture did you find this week for us?"
Like so many things. So many, I know they always are like, how do you come
Right?
up with all of this stuff? I'm like, you just got to know the physics of it, right? And then you can kind of get creative from there. I love that idea
Yeah.
about the
Yeah.
kettlebell one too. I could see that being so functional because, like, think of like everything at home, you're doing, especially, being a busy working parent, you're doing multiple things at once. You got to hold something, you're doing something else. And yeah, I like that. I think it's
Yeah.
really
That
functional.
overhead throwing of like a tennis ball or a small weighted ball, like either on a wall or back and forth to someone. Um, to keep the arm up, and that people have a hard time with that as well. And talking about the upper trap, I went to PT. I've actually been to PT multiple times, but I went once for neck pain because I have migraines, thinking like my upper trap is overused. And actually, I was like not using my upper trap enough. So it like opened my eyes to, all right, there are times like I was one like never worked the upper trap. It's always the issue. And then I was like, oh, okay, well, I need to at least keep my mind open to there are some people who do not utilize upper trap at least properly.
Right. There is a purpose to it. It is a muscle that we need. Yeah. The large majority of people, I feel like, are on the
Yeah.
overutilization side of things. But yeah, there are situations you might need it. Manual wise, things I like. I know we already talked about like thoracic spine, working on mobility there. One, I took a myofascial release course, and one that I really love that a lot of patients feel really good with, and this goes for cervical patients too, is a manual myofascial release of the pectorals. So either have them like hook lying, or even I've done it seated if it's not somebody who can get in that position, and just kind of manually holding pressure like anteriorly. And it's real light with anything myofascial release, but like the amount of like release and relief that you feel, because obviously we have, the muscles and then we have all the fascial overlay. And just like people will feel so much, across that whole area. And it can really help open things up. So especially early on when you're trying to get them out of that really rounded posture, that's when I've had a lot of success with from a manual standpoint. And then just, the various trigger point releases, obviously, all around the area where people get really knotted and sore. But that's kind of my go-to ones, manually speaking.
I'm gonna go back to my dry needling pedestal here, and I feel like that's super helpful with helping people with different things. Like one thing I found is, people that have that really like anterior tilt or like rounded shoulder, getting into that pec minor, releasing that kind of helps them bring that back a little bit easier. Or Katie had mentioned earlier, like the lat will sometimes prevent you from getting that full motion there, kind of stops you. And then when you push past it, their back arches because they can't have that mobility there. So needling the lat muscle kind of helps open that up. And then I feel like almost everyone benefits from a little upper trap release, except for Marcy, apparently. I guess she needs the opposite.
She might still have knots there, right? Just not using it.
Yeah. And this was like my first year of PT. Like I went to PT. I bet now, 11 years later, that I overuse them now. Maybe then I didn't because I was so
They're
like in the
large
flow,
and
like
in
cutting.
charge
But
now.
exactly. I am not very good at manual stuff, so I'm going to take the two things that you guys have talked about and to start incorporating that more into my practice. I think coming from a pediatric world, we just didn't use as much manual stuff because PD patients don't generally tolerate it as much, and so I
Yeah.
need to incorporate that now that I'm seeing more adults. I love the pec minor release, so that's a great idea of things I'm going to do. Yeah, I mean, I do patients, feel better. So I do the like, let me poke my thumbs around your shoulder blades as I like kind of dwell off because I don't love manual stuff. So I'll find a knot and just put my finger in it and be like, see, look, I'm doing something. Um, I have also found a couple times I've really done it, some subscap pressure also tends to help patients. It's not a very comfortable position to get them in or to push into, but it has helped the couple patients I've done it with. But I do need to be better about the manual approach in
I feel like
combination.
with post-op patients, like when they're in that sling for so long, that like that can be really helpful afterward to some of the subscap work. I had a colleague who did a lot of that and kind of, shared some of that wisdom, and that did seem to help for sure. Um, Modality wise, I think I use like the one of the clinics I worked in, obviously ice, for those more acute situations or the post-op patients, like game ready machines or like cryo cuffs. Patients loved those. Like they're like, I only came here today, so I'd get those, 10, 15 minutes at the end to do the cryo cuff. They loved it so much. Um, or the hot packs with more of like the frozen shoulder, the stiff the situation. And I mentioned kinesio taping, the various kind of ones I do for that. I guess that's kind of modality-ish. I think those are the big, I mean, I guess in real acute situations, I've used like stim or like ultrasound. I don't think that I've seen a huge effect on that side of things. But those are there. I don't know. Do you guys have other ones that you use too, modality wise?
Some I've used some like cold laser, or like the red
Oh,
light
yeah.
therapy a little bit, and it's hard for, I mean, I know they're still developing research on that stuff, but
Right.
I have some patients that swear by it and I can use it as like well, this stuff isn't working, let's try this out and see how you
Yeah.
respond to it. So that's always a good one. But yeah,
Yeah.
kinesio tape's a great one. And then, like I said, my needling, cupping as well, kind of goes along with like manual therapy, but anything that maybe feels different, provides some different input into the patient, is worth a shot.
Yeah. Not a huge modality person either. I did PRN at a clinic that every single patient got some ultrasound or some like red laser. Same, I have the same thing. Some people were like, this is amazing, and other people are like, that didn't do anything, which is I think similar to kinesio tape. I'm a person that kinesio tape I don't feel like does anything, but I've had patients who are like, this is amazing. So I worked at a PRN clinic a little bit that did that. Otherwise, not too many actual modalities. But cupping, yes, I wish cupping was like a thing a little earlier in my career. I would have picked it up a little faster, even though it's not super deep. I do feel like patients, for some reason, really respond. At least maybe even just seeing the red circles. I don't know. It's like anytime you watch TV and people see them, they're just like fascinated by that. It was
Right.
like when kinesio tape first became a thing, and I'd be like, at least here in Houston, JJ Watt wears it. It became like or like the
It's
Olympians
gotta be
wear it, and everyone wanted
good.
to do what they did. Yeah. But with manual stuff, going back to that, I have been doing some more like mobilization of the actual shoulder joint as well. I've recently was reading some stuff about stiffness in the like capsulitis issues. So with my patients, even if they're just dyskinesia, I'm like, all right, let me do at least some posterior and generally inferior glides to try and get everything seated better.
Like who can't benefit from that, right? Like it's a rare individual, barring the hypermobile individuals that we often
Yeah.
encounter too. But yeah, then obviously in the frozen shoulder situations or some of those post-op situations where I have some of that capsular tightness and stiffness. Yeah. Um, All right. Any other big areas we want to talk about related to the shoulder? What do you guys think?
I
Last
mean,
tip.
I think we covered a lot of the bases. I mean, Katie had mentioned some studies or like some good CEU courses earlier. One that I just want to throw out there is the athlete movement system. If you haven't seen Jared on MedBridge, he does an upper quarter movement system course, and it's great for anything shoulder related. It also talks about some other parts as well, but it's worth taking a look at if you wanted to dive into the shoulder a little bit more and how to
Is it
treat, how
like
to things.
related to like, so I know I learned like SFMA, like some of those where it kind of breaks it down like that. Is it kind of like that or like a different school of thought?
Kind of similar, yeah. So he kind of breaks it down into like, well, first off, like how do we assess like whether it's a mobility issue, muscle performance issue, or another issue, and then different ways to identify that, and then he kind of progresses to the next thing. Okay, so what now that we know what it is, what's the first part of treatment? What do we do, and how do we weed out what's helpful, what's not helpful, and then he kind of progresses through like higher level activities. So very well broken down, very well structured. And I really like, I just recently actually took one of those courses again. So it's a lot of
Awesome. I'll have
fun.
to check that one out. Yeah, it's a good idea.
Same. Yeah.
Marcy,
Yeah,
did you have
same.
any good
I felt
courses?
like, no, I feel like I got so much shoulders. The big things that we did were shoulder, hip, and knee. So much shoulder stuff that I pretty much avoided taking shoulder. Like I wanted to learn the body parts that I wasn't as well
Right.
versed on.
Yeah, that makes
So I
sense.
haven't taken, yeah, so I haven't taken many shoulder courses, CEU courses, but I'm going to check that one out for sure. And similar, I don't necessarily know if they do just basic CEU, WashU does, but some of the professors do. I mean, they have their own diagnosis system for all body parts. But they do a really good job of walking you through, like, okay, if the scapula is anterior tilted, what that means muscle wise, what that means function wise, what that means for the like glenohumeral joint wise. And that's helpful because there are some schools that don't really cover a lot of some body parts. And there's some schools that I know from talking to their graduates who kind of like, hey, if their shoulder, all we talked about was rotator cuff surgery or replacement surgery or this, and then protocol and what you do after that versus just someone coming in and saying, I have shoulder pain. What is it?
It is interesting, kind of the difference in programs. Like, I don't know, and it probably just depends on who is leading that course and everything and what their specialty is as well. But yeah, the continuing education just makes them more important after the fact so you can kind of identify like where you don't feel as confident, like you were saying. All right, let's wrap up with a shoulder related joke, something funny to make us smile for the day. So I'll start with mine. I'm going to say my shoulder's communication style is passive aggressive. First the cold shoulder, then full on adhesive capsulitis.
I love that one.
Yeah,
I love
yeah,
that
it's
one.
good.
That
I
one makes
told
me
it to you
giggle
before,
every
I know,
time.
but it's a good one. I like it. Which ones do you guys have?
So I don't have a good joke, but I love talking about, what patients call the rotator cuff. And we were talking about this earlier, but I just find it funny how people call it the rotary cup or, my rotational cup or whatever it is. And that's always a fun little thing to think about on how many people don't know what the rotator cuff is.
I think Rotary Cup I've heard so many times, and you're just like, you say it correctly to them, but I'm not going to be like, well, that's actually not.
Yeah, like rotatory cup I've heard. I just enjoy how confident patients are when they say it too. Or like if you're asking them what the doctor said or their MRI results, and they're so confidently say, my rotatory cup is torn or something like that. And you're like, okay. um, I don't have like a joke per se. I sometimes patients will talk about like as they're getting better, they'll say like, I still have like a click or something in my shoulder, and I'll be like, good, that's one thing that's still working. Like try and get them to get over the fact that like noises is a terrible thing.
Right. Yeah. I'm like, man, you should hear me just walk down the stairs in the morning, like little pops and clicks. I'm at the age where that happens now, and I'm like, oh man, yeah, these things are normal. Just
Yeah.
work, loosening back up. All right.
Right.
I'm glad we got to lean into the shoulder. Such a good body part. We'll get into others in the future too. I know you guys have some of your faves as well. But yeah, let us know out there what your favorite body parts are, things you love about the shoulder, things that you find helpful in treating shoulders too. We'd love to hear it. And yeah, anything you guys want to talk about, don't hesitate to share. But yeah, we'll see you next time then. Thanks for stopping in to listen to Luna Unscripted. And yeah, we'll see you back next week.
Bye, everyone.
Bye.
Bye.
Thank you for listening to Luna Unscripted.